Welcome and good morning, ladies and gentlemen, to this beautiful sunny Tuesday morning here in Southeast Michigan. Happy to have you along here today as we talk about CMS's final Medicare rule for contract year 2025 and beyond. My name is Randy Lober, Growth Marketing Manager here at Action Benefits, and part of my job is to help you all grow and maintain your businesses. And one of the easiest ways to do that is to know the rules you're playing by here in the market. I am joined today by Chelsea Smith, one of our learning and development specialists. Chelsea, I want to give you a chance to say hi to the people before we go forward.
Hi, everyone. It's me, Chelsea Smith here, like he said, learning and development specialist. And thank you so much for spending some time here with us at Action to get yourself familiar with those new 2025 final rules for Medicare. So sit back, relax, enjoy the show, and ask any questions you might have. And Randy and I will get to them as soon as we possibly can. So again, thank you so much and enjoy.
Thank you, Chelsea. Thank you for joining us here today, sharing your knowledge and expertise with the session and helping to facilitate the chat and Q&A down below. Speaking of which, down at the bottom of your screen, you do see two ways you can interact with us, one of which is the chat. Feel free to say hi, chat with us, respond there. The Q&A, though, for some inside baseball, does give us a big red flash notification that you have a question you want answered like right now. And we might not answer it right now, but I'm not going to make you wait 55 minutes to answer that question like other webinars might. We want to make sure that you get the answer to your question in a timely fashion where it can still sink in for you. So let's go ahead then and talk about where we want to go today. And first things first, though, especially for the folks that are newer to the market, what is a final rule? Let's figure out what that is first. CMS, the Centers for Medicare and Medicaid Services, each year proposes some rulemaking that regulates Medicare Advantage plans and Part D plans in this market. And that comes out each fall, and that's come out in a variety of iterations. Sometimes they publish regulations in Medicare Marketing Communication Guidelines, but typically and more often we've seen them go through this rulemaking process that gets published in the Federal Register. So we always know there's kind of a few different places we can look for rules, a few different places where we're at, looking at what influences us here in the market. The Federal Register has of late been where we want to go first. And what that does is CMS proposes those rules in November-ish of each year, gives the public about 60 days, or at least 60 days to comment. This year, that comment period on January 5th, of 2024, and of the 1,300 or so comments CMS received, 749, and I know it because I read them, of them had to do with agent broker compensation, which I imagine is what drives 55 or so you hear here today. The final rule does get published in mid-spring, so that we saw that on Thursday, April 3rd, if I do my math right, counting backward. And that's what we want to dive into here today. Chelsea, I, and the rest of the Action team have spent about 40 or so man hours, probably a little bit more, digging in, figuring out what the rule is, what it says, and what it means for you. And what we've discovered is that CMS really has wanted to regulate 5 different areas. And there's some things they didn't say anything about either, which is what's the same bullet you see here on your screen. So these 5 key areas we're going to look at here today are program updates, things that affect the Medicare Advantage and Part D program on the whole, or at least don't fit neatly into those other 4 umbrellas. They also focused on promoting beneficiary access to care in a few different ways. They took a hard look at the supplemental benefits embedded in many Medicare Advantage plans and whether or not they're being used and how they can encourage utilization of those benefits. They spent a lot of time looking at D-SNPS or dual eligible special need plans and figuring out how they can make sure the right people are in the right plans, getting benefits there. They also spent some time with agent broker compensation, which I imagine is why a lot of you are here today. And like I said, there's a few things they didn't say anything about. So a few rules that maybe we've had wonderings about, that we've had questions about, or maybe hoping for clarification on, that CMS did not provide any comment on here today. So I want to give you a little bit of a reminder here toward the end of the session of what those things might be. All that said, I know probably you're going to be curious about agent broker compensation, but I also want to know if there's anything else that you'd prefer we spend a little more time with or might have questions about. So of those areas, what are you most curious about? Is it those broader program updates? How they're promoting access to care, supplemental benefits, D-SNP updates, agent broker comp, or do you want to know what's the same? What did they not talk about here in this rule? All right, for full disclosure, here's what you said you were interested in. So we'll spend some time definitely with those program updates, those broader things here as well. Supplemental benefits is a distant but important third for you. Looking at D-SNPs too. D-SNP is a large and growing market, and what's one thing we want to pay attention to going forward, and you should pay attention to as you're growing your book. Agent broker comp, of course, we're going to spend some time there as well, and we'll give you some of those reminders. Just want to get a sense of what you were interested in here, though we will spend some time with all of these here today. All right, let's dig in. Let's talk about those program updates that you are interested in that are driving some of your attention here today. And want to give you, I guess, a quick overview of how we've set up the slides here going forward. When we say problem here on the left-hand side of your screen, that is not a problem necessarily that we see, and that's important to note, especially coming when we talk about agent broker compensation at the end. This is how CMS has outlined the problem or said this is the problem they're seeing in the market. So on the left-hand side of the screen, we're kind of taking what CMS said and boiling it down for you. On the right-hand side of the screen, we are boiling down their solution that they've finalized here for this year. So this is me telling you what CMS says, not necessarily me endorsing or action endorsing one thing or the other, just so we're all clear on that going forward. So first things first, one thing CMS does is they clarify and make some amendments to Part C and D reporting requirements. As you may or may not know, and regardless of how you feel about the current administration, that current administration, the Biden-Harris administration, has ordered improvements in Part C and D transparency. So CMS takes that order and looks at it and says, well, how can we do that? And in this piece of final rulemaking, what they do, kind of eloquently, is they flex their muscles and remind us all that carriers, they can request data from plan sponsors, red carriers, whether it's a Medicare Advantage plan or Part D plan or both. And they can request that data on a regular basis, and they give a whole bunch of legal justification for requesting that data. And interestingly enough, and again, if you are a legal nerd, this is where you might perk up, they are leveraging some portions of the Paperwork Reduction Act to get that done. In short, what does that mean for you as agents? Probably nothing directly. But what it does do is says to the market and says to carriers that CMS is going to expect and demand that carriers probably report more frequently on things like coverage decisions and diagnosis codes and prior authorization policies and who they're impacting and how and why. Right now that CMS demands a lot of that reporting or asks for that reporting, I'll be gentle with them, on a yearly or semi-annual basis, but the final rule seems to give the impression that we can expect those reports more frequently here as well, to give CMS an idea of how all these different dimensions are shaking out across the market. The other key program update that we throw into this bucket here is they're standardizing the Medicare Advantage risk adjustment data validation appeals process. And you might be saying, huh? In short, what RADV or RADV, depending on who you look to for pronouncing your initialisms, what that does is it is a carrier's right to appeal the rates that CMS reimburses them for covering a certain population. So for example, if CMS and the carriers, they agree on that carrier's initial bid, but actually this that population that the carrier covers is a bit more medically complicated. They have more chronic conditions, so on and so forth, than they have anticipated. They can file an appeal with CMS to get more money, essentially, right, to help offset the cost of care covering that population. What CMS has done here in this final rule here is limiting some of the types of appeals that can begin at once. So making sure we're only focused on one issue at a time. clarifies and streamlines some paperwork that the Secretary of HHS will only issue revised reports once on a final decision, not each time the carrier goes through the appeal process. And if the Secretary of HHS does not review a particular case from the carrier, it makes the hearing officer's decision final. For you, that really means that carrier process or carrier appeals here of RADV are a bit streamlined, and they are likely going to be a little quicker, right? Especially if their secretary does not take on some of that appeal work or chooses not to weigh in on some of those reviews. So you can see, you might not see some immediate boots on the ground impact for you there. Although you may see some adjustments, right? If carriers only have so much money to spend and they're putting less of it into appeals, or perhaps because the appeals process is a bit more stringent, they're not appealing as much, you may see some impact there. Chelsea, I'm seeing some activity in the chat here. Anything we need to pay attention to here at the moment?
As of right now, we have a lot of people asking for a copy of the slides in the webinar, which we will easily provide to you tomorrow morning. Wallace is asking if why MAPD plans can't be appointable through the entire states with the AHIP passing of the AHIP exam.
Yeah.
That would be interesting for sure.
Yeah, Wallace, I see your question, and if I were aligned with CMS, I'd be able to better answer that, right? But in this case, we are definitely just the messengers here. But it is an important question, right? From a carrier perspective, I can understand that they want you to take those carrier certification or those product certification modules, so you are ready and knowledgeable about their products, right, and how you might present them. But that's certainly something worth considering, and on the next round of rulemaking, definitely worth putting your own comment on if you did not do so with this previous round of comments. The second big area CMS talked about in the final rulemaking here was promoting access to care or reducing barriers to care, whichever way you want to slice that. First things first is they want to take a look at utilization management, and that's a fancy health insurance term for all your things like prior auths and denials and appeals processes and things like that. And really the problem CMS sees here is that there is no clear public sense, right? At least that we as the public that's not deeply in tune with the carrier inner workings of every carrier, we don't know who is most impacted by prior auths or other utilization management policies, including step management, step therapies, those sorts of things here as well. So to make sure, or to help ensure rather, that prior auths and other policies are applied in an equitable fashion, CMS is now requiring that carriers add a health equity expert to their committees. Every carrier does have a committee that sets the rules here and makes some decisions about when prior auths will be necessary and so on and so forth. So they're now adding another expert here to the bunch. And they will require plans, i.e. carriers, to publish reports of that impact on any beneficiary who is LIS eligible, any beneficiary who is dual eligible for both Medicaid and Medicare, and beneficiaries who are who may have a disability or be living with a disability. The net effect here is that things are going to get more transparent, right, about how and prior authorizations are being applied to these populations. We're going to see whether there is an issue to be solved here, and CMS hinted that in the future there may be future rulemaking depending on how all this data shakes out. But they concede that they frankly don't know much about the prior authorization, or at least don't know as much as they would like, and requiring this reporting in tune with that previous program update we talked about of data reporting at large will help them move a little bit further in that direction. Another interesting thing, and one I think we can all celebrate, is that CMS does want to improve beneficiary access to behavioral health providers. And that's not just mental health counselors or family therapists. That they put substance abuse providers and other such mental health providers in this umbrella as well. And so to plug some of those gaps, right, and to make sure that mental health services are available to those who need them, they're introducing a new outpatient behavioral health provider type. And like I said, they're lumping marriage and family counselors, substance abuse counselors, everyone into this single type specialist type. Because they're creating this new provider type, that also increases the network adequacy standards for your Medicare Advantage plans. Meaning that in order for a Medicare Advantage plan to bid for a county or to bid for a service area, they're going to need to provide or make sure they're contracted with enough of these mental health provider types in order to keep their contract with CMS. They do take pains to point out that telehealth providers do count too. So if they are able to contract with one of these larger services that are out there as an in-network provider, that can help fill some of the gap for those time and distance standards when they talk about network adequacy here as well. The bottom line impact here for you, though, is your beneficiaries should rather see wider access to behavioral health, no matter what sort of need that might be. And you'll likely see MA providers, especially, beefing up their mental health presence to either bid for or remain in some of their counties, especially if there's some counties where they might be weaker in that regard here at the moment.
Oh, I really just wanted to say really quick before I moved on that I really love this portion of the law and of the final rule because as someone who did the stuff surrounding the COVID debuilding of those policies, I'm really hoping that this will then nudge the COVID era telehealth changes to remain in place. Because there's, like, as Randy mentioned, there's those geographic limitations. There's also those in-person visits that do bring sort of a limitation and a barrier to care to some of those Medicare beneficiaries. And I really think that this is going to be another step towards eliminating that. And I hope that that is what is being encouraged here by CMS and will continue to seep into other areas of mental health care as well. So I just wanted to step in and say that really quick, Randy.
Yeah, and that's a great point, Chelsea. CMS can influence, right? Or they can make this provider type here, but it doesn't necessarily directly impact the DEA, Drug Enforcement Administration, who they oversee some of those prescribing rules around what you can't prescribe via telehealth. But you're absolutely right. This could be a signal that the administration and CMS wants to make permanent those flexibilities. So a lot remains to be seen there. Another thing, and this is probably a big win for your or some of your beneficiaries at least, is that their enhanced appeal rights on non-hospital services. And I want to emphasize the non-hospital here. Currently, the problem CMS sees, and maybe you might be seeing as well, is that you might have an MA enrollee, so a Medicare Advantage enrollee, who's currently staying in a SNF, skilled nursing facility, or maybe they're doing home hospital care, wherever the case might be. And for whatever good reason that Medicare Advantage carrier might have, they decide to terminate those services, whether they're in the SNF or at home or whatever the case might be. And what typically happens, especially in the case of a SNF, is that as soon as the beneficiary is carted out that door, as soon as they leave the facility, they lose their right to appeal that coverage decision. And we all know that carriers sometimes appeal processes take their time, not, imputing any ill will or anything toward carriers, just that there's a bureaucracy there to deal with. What happens though, or what CMS has done in the final rulemaking here is giving those MA enrollees a fast track to kind of parallel exactly what happens for your fee-for-service or your original Medicare enrollees. When the decision is made to terminate care in that SNF, or so they're being kicked out of that SNF or anywhere else, your MA enrollees now have the opportunity to fast track that appeal directly to the Area Quality Improvement Organization, which would handle that appeal on original Medicare's behalf here as well. So it kind of streamlines that process. And most importantly, they do not forfeit their appeal rights as soon as they leave the facility. So maybe if they do leave, but they're able to prove that they do need that level of care, whether it's in the SNF or other care venue, they may be readmitted that way. What you'll probably see from this, or what you will see from this in what CMS alludes to, is that, yes, you'll have the fast-tracked appeals, but if you don't know how to do those appeals here just yet, because maybe you're dealing with, you're more used to MA providers, of course, than original Medicare, or MA carriers than original Medicare, all your relevant notices and plan materials will have to be updated to include these new appeal rights. In short, the big takeaway is there's going to be faster appeals for anyone whose services in one of those facilities is terminated. I do see a question that comes in. We have a natural break here in just a moment. We'll take it up in just a bit. Another big emphasis here was taking a look at Part D medication therapy management, or MTM. And for those of you who may not be as familiar because you're newer to the market, that medication therapy management program takes a look at covered Part D drugs and make sure that they are optimized to better health outcomes and reduce the risk of bad events, right? Including drug interactions. The problem CMS sees here is that only 8% of beneficiaries across all the Medicare program are currently eligible for medication therapy management. So only 8% of these beneficiaries can have are eligible to have all their prescriptions reviewed under this provision of Medicare. And they are seeing that plans are using the most restrictive criteria allowed by law to determine eligibility. So plans, are businesses too, right? They're looking at their overhead, and it does take a little bit of effort, a little bit of outreach, a little bit of calculation from their care teams to administer these MTM programs. So naturally, they're using the most restrictive criteria they can. So CMS has looked at this and said, plans, carriers, if you are going to use the most restrictive criteria, you're going to only do the minimum here to enroll people in this. We're going to increase that minimum and make more people eligible for the program. So now, or in the future, in plan year 2025 and beyond, plan sponsors are going to look for indicators that a beneficiary has any of 10 chronic diseases, and I can give you that list if you're interested in hearing all of them. But they're going to look for the 10 chronic diseases here. They're also going to require sponsors to look for maintenance drugs, even if there's not a diagnosis code on record, right? If a beneficiary is going to the pharmacy for specific drugs, they're going to require plans to audit those drugs that are being taken, and they can't exclude drug classes for that. What I mean by that is one of the targeted conditions is asthma or any respiratory disease. So if you have someone going to the pharmacy and they fill a prescription for a bronchodilator, but not another type of medication here, they have to look at any medication that can be used to treat asthma and determine whether that person may be eligible for MTM. The other thing to point out is that there is a cost component here as well that can make a beneficiary eligible for MTM or not. And right now, what CMS is doing with this final rule here is they're looking at the average cost of 8 generic drugs, right? They figure if someone is taking 8 generic drugs, there's a good chance that their drugs may not interact well or play well with each other, or that maybe they're not getting an optimum health outcome here. So they're looking at people who might be spending that much on their Part D benefit and saying that they're eligible for MTMs to have that care team help the beneficiary and their provider team reevaluate what drugs they should qualify for. Last big thing here before we take that sort of formal break and take some of the questions here in the chat are that formulary updates got a lot easier. Right now, the process is that there's a lot of red tape and time for carriers to update formularies, even if that formulary, they want to bring a generic on board that formulary or biosimilars on board for that formulary. Right now, there's only certain times a year they can do that. They need certain lead times to get that done. And so in this final rule, CMS does make that process easier for carriers, which means as generics can be immediately substituted on the formulary as soon as they become available. Interchangeable biologics can become immediately available on the formulary. Same with unbranded biologics as well. And anyone taking a biosimilar, when those drugs come available, they can be made on the formulary made available with 30 days notice here. Long and short of it is that it's a little bit quicker, a little bit easier for carriers to put new and cheaper drugs on the market, which the hope is should force costs downward. All that said, I've got a question for you all here, and it gives me time to read some of the questions you have coming in. As you think about all of those access updates, we talked about behavioral health, we talked about formulary adjustments, all those sorts of things. What might most immediately benefit your clients? Go ahead and type a few words in the chat here, and we'll take a look at some of those questions that have come in here as well. Okay, seeing a few things come in here. Seeing that Kathleen is really looking at appreciating the mental health thing. Martin asks us if biosimilars include organic medications. Martin, can you give me a little more detail on what you're thinking about it there? I have a gut feeling, but don't want to speak out of turn on what you're asking there. And thank you, Chelsea, for answering that question. That was in the Q&A feature. Again, a lot of you chiming in on mental health as being a thing here. Going to give you a few more seconds to chime in while I take one more sip of water before we take a look at what's happening in the back half here.
That mental health topic is near and dear to me too, as someone who really worries about making sure that everyone has access to the care that they need. Like I said earlier, it can be so much as a transportation issue. It can be that first person in-person meeting before you can start that mental health treatment, and eliminating those barriers is a great way to make sure that we're preventing other heftier medical problems that might occur long-term because those mental health issues aren't getting addressed and exacerbating any of the rest of the other problems that that person might experience because they're not getting that treatment that they need. Those prescriptions going over telehealth as well. If we could address those, that would be another great way. I know they're in the Medicare realm, they are already addressed, but if that could be seeping into, like we talked about earlier, other aspects of health insurance, that would be wonderful. And this is just paving the way to continue to have those great access to those benefits that the beneficiary pays for in the first place.
Hmm. Thank you, Chelsea. And Martin, I see your follow-up here, meaning natural medications as opposed to chemically derived. So again, we should point out that the rule and what Martin's referring to here is this one, where we came back a little bit here, is that carriers now have the ability to make these updates quicker and faster and put these things in. It does not mean they are required to make these updates. So when you're taking a look at organic medications, CMS here is not saying that you have to cover XYZ or organic medication. What they are saying is that it's easier to make those switches for generics or to include these classes of drugs on the formularies. I hope that helps, Martin, and if it doesn't, please let us know. Let's take a look at supplemental benefits. There's a lot to say here, and frankly, if I do say so myself, there's a great opportunity for you as agents here to kind of piggyback on what this rule will bring forth for you, or for us, rather. First thing CMS wants to talk about is SSBCI, or Special Supplemental Benefits for Chronically Ill. And I say SSBCI because I am going to probably slip into that lingo a lot. I want to make sure you know what I'm talking about. It's there at the top of the screen. CMS sees that plans are offering and marketing benefits which may not actually benefit the chronically ill. So they might be advertising a food benefit, or they might be advertising other benefits which aren't really targeting the condition or targeting the list of conditions that qualify as SSBCIs or qualify for the beneficiary to receive SSBCIs, to be more precise. So now what CMS is doing is they're putting a little bit of burden of proof on the carrier, or every carrier. Every time a plan wants to say, yep, this specific benefit, like our OTC food benefit, or this gym membership, or so on and so forth, is meant to help address members with chronic conditions, they also have to provide research backing that up. They can't just, so CMS is no longer taking the carrier's word for it that, yeah, this is good for people with that condition. The other thing you'll see coming out in marketing materials from the carriers is that any benefit that is meant to treat a chronic condition and falls into this SSBCI umbrella must be marketed as such as well. So you'll probably see additional disclaimers, popping into your carrier plan materials and marketing materials here as well. The bottom line here is that there is a little bit more of a burden of proof, right? So to speak, on the carriers. And it might come down to giving us some tighter benefit designs, right? Or some plans that are more specialized for targeting specific chronic conditions. So that could potentially be a good thing coming forward for some of your beneficiaries going forward. The other thing that's to be aware of, and this is one where I see a lot of potential for you as agents, is that beginning with plan year 2026, CMS will require carriers to provide a notice to beneficiaries of any benefits they haven't used so far in that calendar year. In short, CMS is seeing that carriers are throwing out OTC dollars like candy, right? They're giving Silver Sneakers memberships. They're giving all these other things. And utilization, to be frank, is not where CMS would want or expect those benefits to be. So CMS will require, as I said, the carriers to mail a personalized notice to between June 30th and July 31st of each year, letting each beneficiary know what benefits they have not used yet. And that does include mandatory supplemental benefits, so your dental, vision, and hearing plans. It does include optional supplemental benefits, like your DVH buy-ups that might piggyback on those plans here as well. And it also includes any unused SSBCIs, like, hey, you have high cholesterol and you're not using your gym membership or your food here, go do that, right? Go live a healthier life. Here's a reminder for those things. So CMS is hoping that these letters, these communications will increase utilization of these services. And while that might make things a bit more expensive for carriers as the utilization for these things come up, the hope is that if the spend is well justified, right? If the research exists to say that these benefits are good for people, can promote their overall health, it'll reduce long run costs and provide for a healthy beneficiary population going forward.
There is so much money available out there. Sorry, there's so much money out there available right now for your beneficiaries. I just wanted to remind you, there's 67 billion with a B dollars available in rebate funds in 2024 for those beneficiaries. Get out there, get them using that, and the more that they can be informed about that stuff, the better off we're going to be for them as well. Like Randy just said, if the research supports that this is a good thing for them, make sure they have it right front and center and they can use it.
Thanks, Chelsea. I stole a little bit of my thunder here going up. That's okay, but there's enough thunder to go around. But staying in front of your clients as agents is a great way to maintain that relationship with them, right? So think about those two moves, about the SSBCI, that being more forward, right? And that mid-year touch point that carriers must do. How do these two moves, or how can you see these two moves helping your client relationship, especially outside of enrollment season? Take a few moments to write about that, if you could, please. Yeah, Kathleen points out, as well as a few others who are coming in privately here as well, is that it kind of builds in a mid-year reach out for you. Hey, you were supposed to get this letter from the carrier, right? Did you get it? What did it say? Do you need help using this benefit? Karen says it helps her with her own follow-up, right? And we all know the more you stay in your beneficiaries' minds, the more likely you are to stay top of mind, and the more sticky they become with you, the more likely they are to stay with you. So this is another kind of built-in reason to make that mid-year reach out to them. Especially, and it kind of helps you build a cadence, right? If you're doing that first quarter follow-up, hey, you got your new ID cards? How's everything going? Now you've got a kind of a second, third quarter follow-up, depending on when that communication gets sent from the carrier. Hey, how are things going? Did you get that letter? Have you used these benefits? Do you need help using them? How can I help you access that true hearing benefit? Do you have the hearing aids you need? Whatever that might be. So it does help to provide you another avenue for a reminder of that. Let's take a look at D-SNP things here, and I promise we are getting to agent broker comp here as well, but lots of stuff here in this rule. Let's take a look at what's going on in the D-SNP market here. CMS does spend a lot of time here. In short, CMS is finding that there are a lot of D-SNP beneficiaries or dual eligibles who are not enrolled in D-SNP plans. Instead, these dual eligibles are enrolled in regular Medicare Advantage plans, not these ones that coordinate with Medicaid. And if you're at all familiar with D-SNP plans and products, that likely is not a great fit for that person. Because these D-SNP plans do provide more comprehensive benefits. They work with Medicaid to truly ensure that the beneficiary has little to no out-of-pocket responsibility or premium responsibility for that matter for their medical care and dental and hearing and vision, so on and so forth. So there's a few things they do here. First thing they want to do is make it easier for care to be coordinated. So they want to make it, and they recognize that it is hard for if one organization administers the Medicare benefits and another organization administers the Medicaid benefits, they're not great at talking to each other. Carriers don't like playing in the same sandbox very well. So they want to make it more likely that a beneficiary will receive those services from the same plan. To do that, they are now offering instead of a quarterly SEP to dual eligibles, they're offering a monthly SEP to give them flexibility to move. They will limit enrollment in some D-SNPs to those who also get Medicaid benefits from their same organization and limit the number of D-SNPs an org may offer in an area. Typically, we're seeing here down to one HMO, one PPO, although there may be some cases, depending on provider reach and things like that, where you may see more there. So, for you, the bottom line here is standardizing choices for beneficiaries might make coordination and plan selection easier. But my first worry, thinking about what it's like to be a rating agent is rapid disenrollments, right? If they can now change plans monthly, that makes it really imperative that I stick, with my beneficiaries, with my D-SNP beneficiaries, and making sure that, I'm providing the best service to keep them in my book of business and not going elsewhere. Another thing they're doing in the D-SNP market is limiting the out-of-network cost sharing on D-SNP PPOs. What happens is, especially with more traditional PPO designs, and especially in the Medicare Advantage market, those D-SNP PPOs do actually end up charging your dual eligible beneficiaries for any out-of-network services. There's increased copay, increased coinsurance, whatever the case might be. And what happens is that because the beneficiary doesn't have the resources on their own to pay that, either state Medicaid agencies end up footing that bill for the cost sharing, or sometimes the provider gets reimbursed at a rate. They get reimbursed at the local Medicaid rate instead of the original Medicare rate. Providers are going, that's not good business for me. So beginning in 2026, on all D-SNPs, there will be no out-of-network cost share on some common services like PCP visits, specialist visits, hospital visits, or rehab here as well. In-network, out-of-network on those D-SNP PPOs will be the same. And for other services, they will limit it at either 30 or anywhere between 30 to 50% coinsurance on other services, depending on what MOOP the plan is trying to qualify for. I also mentioned a few moments ago that lots of dual eligibles are in plans that are not D-SNPs, right? They're in standard stock off the street Medicare Advantage plans. And like I said, because those D-SNP plans provide some richer benefits to help meet all the needs a D-SNP beneficiary might have, some of our most vulnerable citizens might have, CMS wants to try and limit that here as well. So as CMS looks at the books, right, and looks at a particular carrier's contract, and if 70% of the people in a Medicare Advantage plan are actually dual eligible or should be on a D-SNP plan, CMS will terminate that contract. In 2026, that threshold lowers to 60%, right? And again, the move here is that CMS wants dual eligibles in D-SNP plans to really make that coordination of benefits easier for them. See a few questions from you here before we jump on or move on to agent broker comp. But I also want to know how you see these moves impacting your local D-SNP market. Go ahead and write about that. We'll catch up on the chat here as well. Good clarifying question actually coming in here on the chat. Taking a look at network size of D-SNP plans. Really depends on the carrier, right? What that network might look like. A lot of D-SNPs, at least the PPO D-SNPs, are just as open as the other ones here as well. So your beneficiary may on that plan, on a UHC plan, for example, may go elsewhere, at least on the PPO version of that. but they might currently have those out of network costs here. Helen, good to know about Indiana, and that is certainly, helps to increase access for those beneficiaries here as well. Karen, not talking necessarily about you, the agent here in this case, if you don't have the right number of D-SNPs, just to keep track of everything here. But if the right number of D-SNPs aren't offered by the carrier here, right? So looking at what the carrier or the carriers are offering there, they want to try and limit and standardize the beneficiary choices in those markets here as well. Dave, that's an excellent question, and that's what I mean when I'm concerned about rapid disenrollments. As people, they get more benefits by switching plans. Yeah, that's helpful, right? Because you might get that initial commission, but you're also getting chargebacks for that rapid disenrollment, and I'm concerned about that, right, from the agent perspective. I'm working with that market, and how you stay sticky with those people. Let's talk a little bit about agent broker comp here as we head into the home stretch of our hour here together. First thing first is that CMS took a long, hard look at lead generation companies, and frankly, they're making lead gen and that place in the market a bit harder. CMS has heard and seen there are lots of beneficiary complaints about unsolicited calls, so all those call centers coming up. And what they are doing about that is saying TPMOs, third-party marketing organizations, and in this case, they're using that acronym to refer specifically to lead gen firms. They can't share beneficiary data without written consent of the beneficiary. That means every time a lead gen firm wants to sell a lead to an agent or to another entity, right? The beneficiary has to write and say, yes, I give my permission for XYZ firm to sell my information to ABC agent, or so on and so forth. As you can imagine, we don't think many beneficiaries are going to be all about signing that and saying, yeah, sell my information to everyone. It's going to make it harder. So buying leads may be harder, but for the beneficiaries that do opt into that data sharing and agree to have their beneficiary sold, or they have that information sold, it's potentially a warmer lead, right? If they're really looking for that kind of help. So I guess agent beware here in this case, right? If buying leads has been one of the, the bread and butter of how you attract new business, it may look a little bit different here going forward for you. And now the big stuff. They want to enhance guardrails for agent broker compensation. And again, I'm very clear to call out on the left-hand side that this is CMS's interpretation of the market, not our interpretation of the market. But what they are seeing and what they are believing is that improper compensation causes agents to steer beneficiaries into plans that aren't great fits for them. Instead, they're really worried about steering, right? They're worried that agents or bad actors might be putting people in plans that line their own pockets, right? Line the agent's pockets that aren't great fits for the beneficiaries. One thing they're doing here is eliminating some contract terms between carriers and FMOs, and therefore FMOs and their agents. One thing that they specifically call out in this rulemaking over and over again is the idea of a volume-based bonus or a volume-based incentive. So a carrier can't say to Action Benefits or any other FMO, if 40% of your book is this color, right? If we have 40% of your book, we're going to give you a little extra bonus here. They also can't set flat numbers. So they can't say if you enroll 250 MAPD contracts with us, we're going to give you a little extra bonus here. Nor can FMOs or anyone else provide incentives for agents that same way. So anywhere you see a volume-based incentive for Medicare Advantage enrollment or Part D enrollment, what this does really is eliminate that. And there's other programs certainly you'd want to look at here as well. But anything that encourages you or would have the appearance of causing an agent to steer a beneficiary toward that plan would be outlawed here under this provision. The other thing CMS says a lot about here, again, under steering, is they want to take a quick or really hard look at what compensation means here. It used to be, back before this final rule, that there were two ways you could bucket compensation. One is in commissions, which you all know and love, hopefully. And the other bucket you could, that carriers could pay agents and FMOs could pay agents under was admin payments. And what they found out that a lot of admin payments are actually disguised as golf trips or reward programs or things like that, specifically for MAPD or Part D enrollments or MA enrollments, I guess, too. And what they've done is they've put the kibosh on the admin payments, and now there's just one type of compensation that either carriers or FMOs may render to you, independent health insurance agents. And that definition of compensation also includes all enrollment-related activities, which means there will no longer be additional payments for things like health risk assessments. Everything that you might reasonably do around new enrollment is covered into this new compensation definition here. CMS does recognize, however, that they've undervalued in a lot of ways the work that goes along with that enrollment, that goes along with the HRA and everything else. And this year, they're giving you a $100 one-time raise for initial MA and Part D enrollments to kind of make up for any compensation you might be losing as a result of those HRA payments disappearing and things of the sort. And then we'll continue to see yearly adjustments in fair market value going forward. The bottom line here, though, is that you can only earn what CMS allows on a per enrollment basis. And violators, CMS does remind us, are subject to federal anti-kickback laws. So if there may be someone out there, there may be other FMOs out there paying you on a per, or paying other agents because they're not paying you. You're not breaking the law. But there may be other FMOs out there paying other agents above and beyond what CMS allows. They might be saying, hey, we'll give you another $50 per enrollment. That's expressly forbidden and what CMS is trying to crack down here. And again, violators can be subject to anti-kickback laws here. So that being said, I want to hear from you. What adjustments might you need to make for generating new business, or any other questions you have here while we take a look at and catch up on the chat? Dave and Leslie are actually, and Chelsea's replying to them here too as I'm catching up here on the chat. They're saying, these call centers are out there. They're the ones breaking the rules, and they're the ones that need tighter regulation. And remember back at the beginning, or toward the beginning of our hour together here, I said there was about 750 or so comments that dealt with agent record comp, this part of the rule and everything else. And it became increasingly clear that CMS isn't fully aware of the scope of the problem that call centers may be presenting to you, and likewise going forward. And frankly, your comments, whether there's whether they came from you or the agent community at large, did a lot to educate them about that. I would expect more rulemaking and certainly possibly when CMS is resourced to do so, further enforcement action against those call centers. But it seemed fairly clear that CMS was not aware of the scope of the problem going forward. Word of mouth is very important going forward, and as Kathleen and Dan mentioned here too. Dave asked if carriers can have different commission structures if you do an HRA. And the long and short of it is this: every carrier can only pay you fair market value, whatever CMS sets as the rate for that year going forward. So I doubt any carrier, thinking from a business perspective, I doubt they're going to offer you one commission rate below fair market value and then bump you up to FMV for doing the HRA. I would anticipate that you would see everyone offering FMV and full fair market value, and the HRA payment you've been accustomed to would be just rolled into that FMV, right? I wouldn't expect any additional payments there. Also want to spend some time with what's the same here. What did not change, and what are some rules that you might have been hoping to see change but didn't? First thing I want to remind you of is that this rule here in 2024 for planning 2025, the 48-hour rule remains in effect. Did not change at all. CMS did not say anything about it. Did not say it's been hard for anyone, for easier for anyone. Weren't many comments about it. So the 48-hour rule, as you know today, still stands. It's alive and well and back from the dead. Other thing we should point out is that the event scheduling rules are still in effect here as well. So as a reminder, you can't schedule marketing events within 12 hours of an educational event at the same location. Again, some of you, when we were talking with you last year, had a little bit of concern about that, right? What if I have the educational event, have the marketing event stacked right up after that? It's an easy way for me to generate leads. And CMS says, nope, not changing that this year. The prohibition on collecting SOAs at educational events, scopes of employment, is still in effect here as well. So that is but you can, however, give out business reply cards or lead cards or consent to contact there as well. Speaking of consent to contact, that consent to contact is only valid for 12 months going forward. And we should note that the disclaimer is unchanged. So you know how right now, every time you have a call, and it has to be recorded, if you don't offer all plans, you have one set of words. If you do offer all plans, you have another set of words. That is all intact. CMS had nothing to say about those disclaimers here as well. So we'll keep on keeping on in that range going forward. If you have not seen, I do want to see if this pops up for you here. And I'm going to switch over here. To help you comply with that rule, we do have a guide for you on our website. Don't sweat the Medicare disclaimer here. Gives you, all of the a county by county view of what's available where and when. Gives you a reminder of the disclaimers here as well. And of course, it gives you a link to our call recording solution and to Coverage for One, where you can shop, quote, and enroll across all these carriers too. So you have that available and as you may need it. As we, are in our last few minutes here together here today, I promised you we'll be here an hour, and we're here for 56 minutes of it. There's a lot to talk about here in the last 56 minutes or so, a lot to keep you informed about what's going on in your industry. And of course, I want to thank you for your time and attention, not only for spending time with us, but for taking the time to better serve your beneficiaries by being, involved here in what's going on. Should you have any questions, this is a great time to ask them, but I also want to let you know that the fun doesn't have to stop here. You can always follow us on LinkedIn at the Action Benefits Company. If you have any questions about today's presentation, you're welcome to reach out to your account manager or to Chelsea and I directly at learning@actionbenefits.com, or you're free to call our main line, 248-356-8585, and we'll get you in touch with who you need to get in touch with from there. Chelsea, before we take a spin through the questions in chat, any final words you have for our audience before we go forward?
Thank you all so much for spending some time with us here today. I know that these are very complicated rule changes, and there's a lot to remember and a lot that might affect the way that you're going to run your book of business moving forward. But just always remember that we at Action are here for you to help, whether it be us as your marketing team, whether that be your account manager, no matter what, we are here to help you, and please feel free to reach out to any of us at any time for any help that you might need.
Thank you, Chelsea. And John, you have an important question there. I want to mention that up the top. John asks us, how about carriers paying overrides to top-level FMOs? And good news is FMOs are still around under this rule. CMS has nothing to say about overrides going to FMOs in this case, although they have a lot to say about FMOs or about overrides not going to agents, right? That's part of capping FMV, fair market value, as what agents receive. But right now, and I want to emphasize right now, the payment structure that funds FMOs and their activities appears to be untouched by the rule. Although certainly as we look forward and when new contracts come up, we'd have to take a careful look at all those contracts going forward here as well. Saw another question come in privately about things like Humana's marketing reimbursement program. So, and for those of you who don't know, Humana does provide some marketing reimbursement for agents that write with them. And some of you may be going, is that steering? If Humana provides me extra marketing dollars or reimburses me to write business with them. And Humana hasn't said for sure yet what the future of that program might be. But if we're kind of looking at the intent of the rule here, I I would anticipate that, we'll be hearing some news from Humana around that program and some other similar programs going forward. So be on the lookout for that. That'll be kind of the bellwether for how larger carriers, national carriers are interpreting the rule, and we'll see how that interpretation trickles down to regional and local carriers as well. Great question. All that said, we are here at 11 o'clock. Again, thank you for your time and attention here today. Always love spending time with you. And if you have any more questions, please feel free to keep them coming. You're going to hear us stop the recording here at the end of the hour. But Chelsea and I are happy to stick around for anything else you have for us here today. Thank you to everyone saying thank you. Always, like I said, enjoy spending time with you here today.